dear colleagues, in the history of medicine, whatever number we are talking about, 100,000 years or 5,000 years since the first breast cancer was published, there has never been any other physician generation that could decrease mortality from breast cancer. And it's so sad that all the way up to the 1970s, women had this kind of cancers, ulcerated, advanced, with a very high fatality rate. Would you mind patting yourself on the back a little bit? Please do that. It's us, the radiologists, who created a revolution after we started to use low-dose film screen mammography, digital mammography. So this went down to this size. She already had the disease, but she didn't know about it. Non-palpable. The paradigm shift is this. We replace the mainly palpable with the mainly non-palpable cancers. And you know the result. Mortality decreased among those women who participate screening by 50 to 60%. But it's such a complex organ when it's normal. So many diseases, benign and malignant, it develops. It's really required that we have soldiers to win the war. And that's right. Training radiologists to find early cancer is so vital. This time, we have chosen asymmetric density on the mammogram. What does that mean? You have a density on this part of the left breast, and in the corresponding area of the other breast, there is no such density. So there you sit and scratch your head. What is this? This one is difficult, mostly because the vast majority of the mammograms are normal. Asymmetric density, but still normal. So then, should I call back? Shouldn't I call back? What is the proper callback rate? So we are going to follow a very didactic approach. First of all, I'm going to show you many normal mammograms. And we call it specific asymmetric density, which means normal fibroglandular tissue. This is the most difficult in mammography, to say, I am absolutely sure that Mrs. X, you do not have a cancer. Very difficult. Now I raise the bar and go from the unequivocal to the equivocal. And how do I make a distinction between the two? That's going to be a big topic. Non-specific asymmetric density can be without architectural distortion, and it can be with architectural distortion. What do you think? Which one is responsible for most of the mistakes radiologists are making? This one. The stellate lesion, when it measures about 10, 15 millimeter, has a nice central tumor mass, straight speculations, yes. But when it's a baby, then it's just a smudge without architectural distortion. And that's where most of the mistakes are. That is, we miss cancers. That's what is difficult. Architectural distortion, yeah, it's difficult when concerning perception. After that, we are going to spend so much time on the differential diagnosis. I think having a cyst in this area, a fibroadenoma, a palpable cancer or non-palpable cancer, fairly large size, that's not a big deal. This is a differential diagnostic problem, not much of a perception problem. Normal fibroglandular tissue can be symmetrical. There is no asymmetric density. That we can handle. When there is an asymmetric density, I am absolutely sure this is a normal parenchyma. How can you be so sure? I wish all of you had this beautiful collage printed up on an A3 paper, laminated preferably, while you are screening, because that teaches you what the underlying histology looks like. But this is what I'm seeing, a 1.5 to 2 millimeter nodular density. radio-opaque. The fat is radiolucent. While looking at the black and white, you are always thinking in color. For example, this linear density here and linear density there, that's a reflection of the underlying major lactiferous duct. This is such a great teaching tool. Well, of course, this is a harmonious image, entirely normal. Well, this is our biggest problem. Unlike any other organ in the body, the mammograms, the breasts, are varying from woman to woman and with a 10 or 15 years difference, even in the same woman. Whether you look at the screening mammogram that is asymptomatic women, or you look at the mammograms of your 1,000 referred cases, palpable lump, breast pain, and so on, most of them are normal. And we know the statistics. If I screen 40 to 74-year-old women, first time, never had a mammogram, we are expecting about 6 or 7 cancers among 1,000 women. And then the next time, there will be 5, 6, 7 cancers in the same 1,000 and in the same 1,000. Now, that's 0.6.7%. Well, of course, there are the hyperplastic breast changes, the radial scars, the non-calcified ill-defined, and the ill-defined calcified fibroadenomas, the papillomas, the different adenoses, sclerosing adenoses, and so on. Still, in this population, together with this one, would be about 40 per 1,000. Does this mean I should call back 4%? Well, I'm not going to tell you what you should call back, but this is the underlying philosophy. I think that these courses dealing with the non-calcified densities and the normal mammograms are going to help you to find the happy medium. For that, you have to think in pathology. This ingenious gentleman, a colleague, told, listen, you can never be a good physician if you don't understand the underlying pathology of the disease you are facing. So I'm going to rewrite this. You can never be a good breast imager if you don't understand the underlying histopathology of the breast. But I'm not going to scare you by asking, you should know everything about the cells and the mitosis and so on. No. And here is a problem. People don't think in 3D histopathology. You have to think in underlying structure and compare with the mammogram, with the ultrasound, with the MR, and other imaging methods. During our randomized control trial, I wanted to compare the mammograms with the histology. But then we found out that the histology had enormously high resolution. And this is the lowest power histopathology. That is, they didn't magnify it yet under the microscope. But even if we decrease the resolution of histology, I cannot compare it with my mammogram because they still show cells. I never see cells on the mammogram. I never see cells in the ultrasound and the MR. So what we did was the following. Namely, we increased the resolution of mammography, and it's called microfocus magnification. And then we decreased the resolution of histology, and dear colleagues, that's called three-dimensional histology, which means that we took a piece of tissue and diligent histopathology technologists sliced 1,500 micron, 1.5 to 2 millimeter sections. And then the cells are gone. And imagine what's left. The three-dimensional histology. When I'm saying a duct, you see a tube. But I see spherical cavities here. Cyst-like structures. Actually, this is a Swiss cheese disease. I promise to you, we are going to look at normal mammograms. There are 4 basic building blocks. I'm only using 3D. No cells, but structure. Here is the milk factory. It has this pen handle, so to speak. That's called the terminal duct. The lobule has 50 fingers, sometimes 120. Then we call it adenosis. Dear colleagues, this is the acinus, and in these acini, the milk was produced one day. But it's unfortunate that the same cells may produce as many as 75% of all cancers. So let me play the role of a radiologist. Here comes the X-ray beam. It hits this one. Now, what do you think the shadow of this is going to be? This tiny little, what did we say about the size? 1.5 to 2 millimeter nodular, oval-shaped density. This is going to be the most important, most frequent finding, basic building block number 1. But then suddenly you can ask the question, now how come that we can see this separated from the other and from the third? Because we have a friend here among them. It's called adipose tissue. We love it. That separates the TDLUs from each other. And as I mentioned to you, it may be so that the acini are longer and more numerous. It's called adenosis. And of course, the X-ray tube, again, it's going to be nodular density, but much larger than this one. You immediately think more cells because it's longer and because it's 120, not 50. What is cancer? Cancer is the malignant proliferation of the epithelial cells, whether it's on the surface, on the skin, the lining of the stomach, lining of the acini. That's called cancer. So this is a high risk. This is the only high risk pattern in the breast. Let's go back to the basics. We talked about 1 and we talked about 2, and here is basic building block number 3. Its reflection is going to be this one. Linear density and fat and linear density and fat. Wonderful. That's going to be the duct. Suddenly, you understand, I understand most of 3 out of the 4 basic building blocks. Trouble is around the corner. And then your face and my face looks like this. It's called fibrosis. It's called mesenchyme. It's called fibrous connective tissue. Why is it a trouble? Because it hides the TDLUs, and that's where the cancer originates from. There is a cancer here, and I cannot see it. I'm not going to be happy. You have to be an extremely good radiologist and very patient, saying concave, concave, concave. Whoops, there is a little bit of a convex contour here. This is the same thing in 3D. This is the tip of the iceberg, and the rest of the iceberg is just hidden in this fibrosis. This could have been right in the middle. And then I look like this. There is no radiologist on earth who can find this cancer just by using mammography. So we are going to talk about multimodality approach. Sometimes we are so happy that we see the whiskers. Look at this, called the tip of the iceberg. Here is the body of the iceberg. Dear colleagues, that's it. You got it. Now you know what the 4 basic building blocks are. And I always love comparison with plants, flowers. The trunk of the tree is here, and the tree has branches. Did you recognize that a tree doesn't need many branches? The tree needs a lot of leaves. And you see the comparison here? Here is the main lactiferous duct, its branches, and women don't need many ducts. What do women need? A lot of milk factories, terminal ductal lobule units. And when she's aging, these are going to disappear. When winter time comes, these are going to disappear. And the ducts become skinny. Ducts don't change. Wintertime, springtime, they change the TDLUs. I tell you, Mrs. X, you don't have any mammographic abnormality. Let's practice. If it's a linear density, then it's a duct. And what are these beans here? Tiny, tiny, tiny. I have to magnify. Yeah, those are the milk factories. And then the fat and adipose tissue in between. So I'm actually looking for harmony. The cancer is going to change this beautiful picture quite dramatically. I look at the black and white, and my brain works like this. The lung is a duct, and the circular oval-shaped is the terminal ductal lobular unit. And the rest should really make you love looking at a mammogram. Let me see another mammogram, because I know what this is, because I'm thinking about 3D pathology, not cells. You gained one more thing. You know histology. You are a partner. I teach you the structure from the cells piece of cake. This is what we call the basic building block number 2, the duct. This is what we call basic building block number 1. How come that they are varying in size? Well, one of your children is taller than the other one. Both of them are normal. Oh, within certain limits. So this was basic building block number 1. And here comes something which makes us look like this, the yellow, the fibrosis. And here is something that makes us look like this. It's called adipose tissue or fat. So now I take you to the multi-headed microscope. You are a partner of the pathologist sitting beside you. Why? Because this is adipose tissue. Here are the fat cells. Great. And this one we very much dislike. The red is the fibrous tissue. And where is the duct? The duct cross-section is right here. Ducts normally are pleated when they contain cancer or fluid. Then the pleat's gone. But right now, here is the duct and here is another duct. 1, 2, 3, and the leaves on the tree, the milk factories, smaller, larger TDLUs. Don't be afraid anymore looking at a histology. We could say, well, I'd like to see it in 3D. And this is going to be the lobule. This is a terminal duct. Then we call it terminal ductal lobular unit. And here is a subsegmental duct. Just look at this for a second. What a beautiful organ. I wrote a book about prostate and breast, brother and sister organs. You cannot imagine how boring the prostate is, because it doesn't have fat. Just look at this. Here is a terminal duct and the terminal ductal lobular units. A little bit of atrophy here, a little bit of more fingers here, a little bit of atrophy here, somewhat larger TDLU, somewhat smaller TDLU, fat. But basically, this is a dense breast. This is a young woman's dense breast. I see nothing of this on the mammogram. And then we are going to stop here and say, where are the 4 basic building blocks? No problem for me. This is fat. The red is fibrosis. This is a cross-section of a duct and another duct, and the rest are TDLUs. Isn't that beautiful? Then we go on. This is more entertaining. I'm just wondering whether you hear the music, but anyway, color, black and white color. I don't think it needs explanation. We just have to practice. And here is the beauty again, compared with flowers. The only difference between the two is that fluid is transported from the roots to the buds and to the flower, this direction. Here, the fluid is produced here. It's called milk. and it is transported in that direction to the mouth of the kid. That explains why these two are so similar. Wonderful. Dear colleagues, I'm producing these collages. I made the flowers look small here because the TDLUs are small and normal. I made the flowers big here because this is a TDLU that has 120 fingers. What's the name of it? Adenosis. Later on we can talk about sclerosing adenosis, blunt duct adenosis. And then we are in trouble because there is powdery calcification, one cluster and another one, and the third one. And it's 50% chance that it's sclerosing adenosis and 50% chance that it's going to be grade 1 carcinoma in situ within a TDLU. Normal fibrogranular tissue, you look at this and your brain has this in front of you. I had to insert here something. How to read a mammogram. Oh, you think you know how to read a mammogram? I'd like to find out whether you really know how to read a mammogram. Let me tell you something about the history. Quite recently I was thinking about that the Swedish WE trial, of which I was the director in this arm and my colleague Gunnar Fagerberg on the other arm, I believe that the success of this trial depended on this black box. Now, I'm using yellow color here because my friends who are sitting right at this course, Jonathan and Catherine, they were so kind to give me a present. They sprayed gold on this. And they actually wanted to express to me that it really is worth gold. Why? What did this do? There are glasses here. What does this do? Enlarge the picture. That was just one thing. And it cut out the extraneous light. Part of the mammogram, let's say the axillary tail, we had to move with that. And then we invented the side-by-side, step-by-step viewing very meticulously. This is my message for you today. This is going to be one of the most important things you're going to learn. You should never view a mammogram without enlargement and without making the mammogram darker. Quite recently, I talked with a colleague and their viewing station looked like this. This is the current MLO, right and left, and this is the current CC, and this is the previous, and this is the previous, and the previous, and the previous, and previous. Excuse me. I guarantee you are missing cancer. It's called information overload. You should never view mammograms like this. Please listen to me. I'm going to prove it to you today how much you are going to miss if you view the mammograms like this. You shouldn't view the mammograms this way either. Let me show you how to view a mammogram. I'm going to ask you a question. This is her first examination. And this is her CC projection. Is this how you view a mammogram? Back and forth? In that case, let me ask you a question. And the question is on the Slido. Would you call her back? You have to answer two questions, right or left. Somebody want to call her back for the right breast. Right and left breast, okay. Good enough. You see how it evolves? I have another pair of questions for you. Those of you who want to call back, is it asymmetric density or microcalcifications? You have the right to look at the mammogram again. My question is, most of you wanted to call back for the right breast, asymmetric density or calcifications. Let's see. Asymmetric density. My first point was, let's magnify. You bought a fantastic tool and it's in front of you and you don't use this part. Tell me, why don't you use this? I think you should. I think we all should use it. And this is the way to do. Like this. Until the skin touches the edge of the monitor. Side by side, 2 seconds, normal lymph nodes, thank you. Later on, we are going to talk about the Milky Way. I don't see any asymmetric density or calcifications. I look at the contour. And then you thought that this was a density. Did you see what I did? I darkened it. And I suddenly see TDLUs and TDLUs and fat and fat. I want to show this here as well. Too dark, lighter, I can operate with it. I have to answer the question. Do I really see a circular lesion? No. A stellate lesion with a central tumor mass? No. Calcifications? No. So why the anxiety? I think it's a normal parenchyma. Prove it. She comes back 2 years later. And 2 years later, her mammogram looks like this. These are TDLUs. The lower half of the breast very early loses the TDLUs. That's why the nipples go down. That's why most of the breast cancers originate in the upper half of the breast, because most of the TDLUs are here, and 75% of the cancers originate from the TDLUs. So it's only natural that most of the cancers are in the upper half, circular or stellate. Let's look at the CC projection of the same case. Window leveling a little bit. Please take home message. Don't ever look at a mammogram without enlarging and making the picture darker. And then I show you, just to gain credibility, another 2 years later. And so you make it darker, which means I develop the fat. And it's all TDLU and fat and TDLU fat. And then here is another important thing. Say, is this a circular lesion? No. Is this a stellate lesion? Are you kidding? No. So what's your problem? I have no problem. Thank you very much. Welcome back to next screening.